Good morning, dear audience. My PhD title has already presented Dr. Deci, so I would like to start it. I'm working as a resident doctor at the Pediatric Center, Semmelweis University, and my supervisor is Miklós Garami. My SMSs are Vanda Máté and Mahmoud Obeidat, and my statisticians are Szilvia Kisdala and Gergely Agócs. My vision is to improve the life quality and extend the life expectancy of children treated with brain cancer, and my mission is to provide guidelines for these patients with hydrocephalus and malignancies. I've got two ongoing projects. The first one is about ventriculoperitoneal shunt infections, and the second one is about oral targeted therapy in brain cancers. So my first topic is shifting paradigms, antibiotic-impregnated ventriculoperitoneal shunts for infection prevention. 1 in 500 to 1 in 1,000 babies are born with hydrocephalus, but there are several reasons which can lead to this condition. For example, intracranial hemorrhage, malignancies, or trauma. Ventriculoperitoneal shunt is the most common treatment for this condition, and an estimated 30,000 VP shunt procedures are performed yearly in the United States. The problem is that the incidence of infection is still really high. It's between 3 and 20%, and it can lead, for example, to 2 times higher mortality and cognitive impairment. Our aim is to compare the rate of bacterial VP shunt infection with or without antibiotic prophylaxis. Here the population will be all patients with VP shunts, so also adults and children, and the intervention will be an antibiotic impregnated shunt, which is impregnated with rifampicin and vancomycin. We hypothesize that the rate of bacterial infections decreases with this antibiotic prophylaxis. So I've conducted my systematic search at the end of November 2022. I had 3 main domains: the ventriculoperitoneal shunt domain, infection domain, and prophylaxis and treatment domain. First, I had more than 10,000 hits, and at the end I had 27 full eligible articles. 4 of them are randomized control trials, and the other 23 are retrospective observational cohort studies. This is my main forest plot, which is about infection in a mixed population. Here the measure of effect was odds ratio. If the odds ratio is below 1, that means that antibiotic impregnated shunt has a protective effect against bacterial VP shunt infections. Here the overall odds ratio was 0.44, which means that if we use a standard ventriculoperitoneal shunt, then we will have a 2.5 times higher chance to get a bacterial VP shunt infection. This result was also statistically and clinically significant. This is my second forest plot, which is also about the incidence of infection, but here I have 2 subgroups based on the age. So my first subgroup is children, and my second subgroup is about adults. Here the overall odds ratio is 0.38, which also means that antibiotic impregnated shunt here has a protective factor against bacterial infections. Our results suggest a tendency that it can be even more effective in children. So my third forest plot is about shunt failure in a mixed population. I think that this is really important because if a patient has a shunt failure, then you have to remove the ventriculoperitoneal shunt, and after that you have to use an external ventricular device, and maybe you should also give them systematic antibiotics. And after the healing, you should also perform another ventriculoperitoneal shunt procedure, which can cause emotional and financial difficulties for the patients and for the clinicians. Here I had 4 randomized control trials and 5 retrospective observational cohort studies. The overall odds ratio is 0.73, which suggests that antibiotic impregnated shunt can be also effective in preventing shunt failure. But as you can see in the article of Atonello, the odds ratio was 0.34. Here the population was only children who had a planned surgery and who didn't have so many risk factors. That's why it could be more efficient here, this antibiotic impregnated shunt. But for example, in the article of Wong, the odds ratio is 1.27. Here the population was only adults who had an urgent surgery because of trauma or intracranial hemorrhage, and they had several other risk factors like steroid treatment, diabetes, and some other chronic diseases. That's why in this case the antibiotic impregnated shunt was not so efficient. But at the end, we would like to suggest to use antibiotic impregnated shunt to prevent shunt failures, because the main reason of shunt failure is still the infection. The strength of my meta-analysis was that I had a large number of patients, and the articles were written in 9 different countries. The limitations are that I only had like 4 randomized controlled trials, and we saw an absence in some articles of the detailed age grouping. The conclusion is that antibiotic impregnated shunts decrease the rate of bacterial VP shunt infections to about 1/3, and the implication for practice is to use these antibiotic impregnated shunts whenever it's available. The implication for the research is that more RCTs are needed in investigating the rate of shunt failures, and adults and children should be investigated separately. So the article draft is finished, and I'm planning to send it to internal review this weekend. My target journal is Journal of Neurology, Neurosurgery and Psychiatry, which is a D1 journal. My second topic is about precision therapy with the oral anti-cancer drug dabrafenib in pediatric brain malignancies. So about 30% of childhood malignancies are brain tumor, but the 5-year survival rate is only 75% with the conventional therapy. The conventional therapy means surgery, chemotherapy, and radiotherapy. In case of BRAF mutation, for example, we can use oral targeted therapy, dabrafenib, which had a really good clinical activity and an acceptable tolerability in patients. At the Pediatric Center, Semmelweis University, we also use this targeted therapy, for example, for pilocytic astrocytoma, but we don't really have human data about the cerebrospinal pharmacokinetics. That's where our aim is to define the optimal dose of oral dabrafenib in children treated with brain cancer to reach an adequate cerebrospinal fluid concentration. Our clinical question is that how can dabrafenib doses be optimized individually by monitoring drug levels in blood and also in the cerebrospinal fluid. We hypothesize that oral dabrafenib therapy cannot reach the therapeutic level in the cerebrospinal fluid given in the usual dose. That's why our clinical implication is to provide recommendations for optimal dabrafenib dosing. To summarize, I'm planning to finish my projects at the end of September. And here is my favorite quote from Kurt Vonnegut, who was an American writer. "Science is magic that works." And really thank you for your attention.
What is the difference between the adult and children population? Why did you find this difference between the two groups?
Thank you for your questions, first of all. And as I mentioned at my third forest plot, children have not so many risk factors. For example, like the adults have chronic diseases. In Hungary, more or less, everyone has diabetes and hypertension. So that's why it could be even more successful in children.
Have you planned to have a subgroup analysis based on the type of the bacteria or not?
Thank you for your question. I had missing data about this. So I had only a few articles where they wrote the exact bacteria, so I cannot do it.
I just want to ask, because when I was working on my project, I found out that there is a lack of data from United States or from Europe for my project. So regarding these 9 countries, I would be interested, like, from where are these countries located, like if it's Europe, Asia, or United States. Thank you.
Thank you for your question. So the most articles were written in the United Kingdom, and some of them was like 3 or 4 in South Africa. I had 2 articles from China, from Spain, and from Turkey, and from Italy. And I also had some articles from the United States, so that's all.
How many children do you have with dabrafenib? How many children are taking dabrafenib? And do you plan to measure them only in our clinic or countrywide in the other oncology departments also?
Thank you for your question. So right now I have about 10 patients who are taking dabrafenib, but we are expecting more patients in the next year. And actually we had a conference like 3 weeks ago, and we were discussing about this because at Szeged, Miskolc, Pécs and Debrecen, they also treat children with brain cancer. And we told them that we are waiting for the blood samples to measure the drug level from there too.
What do you think, why this antibiotic impregnated shunt is not used in hospital, or what's the reason when they use it?
Thank you for your question. I think that, but this is only my opinion, that it's because of the price, because you know this antibiotic impregnated shunt is like 4 times more expensive than the standard shunt. And my opinion to that, maybe they were waiting for more data about this. But luckily, like 2 years ago, they had a really big randomized control trial in Britain, which also contained silver impregnated shunt, antibiotic impregnated shunt, and standard VP shunt. Or maybe they were waiting for my meta-analysis to start using.
Of course.